Welcome to New Retina Radio Journal Club with VBS. My name is Katherine Talcott, and I practice at Cole Eye Institute Cleveland Clinic. I'm joined today by Kyle Kovacs from Cornell in New York City.
Hi, Kat. Great to be here.
Thanks for coming. And Rebecca Soares from Ophthalmic Consultants of Boston.
Thanks for having me.
Great. So today we're going to be discussing a paper entitled Impact of Retina Fluid-Free Months on Outcomes in Neovascular AMD by David Eichenbaum et al. That was printed in Retina in February of this year. Kyle, do you mind summarizing the paper for us?
Sure. So the Hawk and Harrier studies, which this paper is sort of covering, were phase 3 pivotal trials examining the safety and efficacy of brolucizumab for the treatment of neovascular AMD. The comparison arm was with aflibercept, and as a reminder, the study was designed with 3 monthly loading doses followed by Q8 week aflibercept with either Q12 or Q8 week brolucizumab. The fluid status in Hawk and Harrier was assessed monthly, and in this analysis of the Hawk and Harrier studies, researchers grouped patients into 5 categories based on how many fluid-free visits, which is a big term we'll come back to multiple times, they experienced during the study. And then they also described the nature of the residual fluid status. And it's worth noting that for this study, this was a pooled analysis of all the patients in the Hawk and Harrier, regardless of what medication they were receiving. So the fluid-free visit was defined in 3 different ways for the study. So either 1, they had no intraretinal fluid or subretinal fluid, no intraretinal fluid with or without subretinal fluid, and no subretinal fluid with or without intraretinal fluid. The first eligible visit to be categorized as a fluid-free visit was after the loading phase, so after those first 3 injections. Patients were then placed into categories based on increments of 7, so what number of fluid-free visits. So category 1 meant that they were never dry. They had 0 fluid-free visits. Category 2, they had between 1 and 7 fluid-free visits. Category 3, they had between 8 and 14 fluid-free visits. Category 4, 15 to 21 fluid-free visits. And category 5, always dry, 22 fluid-free visits. Their endpoints were the number of fluid-free visits, the change in the best corrected visual acuity from baseline, and the change of central subfield thickness from baseline. That was a whole lot, so I apologize, but it's kind of integral for the rest of it. Their findings here was that the largest cohort of patients was in category 4, so those that had predominantly fluid-free visits, and that represented the bulk of their patients, 39 to 43%. When fluid-free visits were defined as intraretinal fluid always being negative, 37% of patients were in category 5, as opposed to having both intraretinal fluid and subretinal fluid negative, in which case 6% of patients were in category 1, which was never dry. It's tough to keep it all together, I know. The largest change in best corrected visual acuity occurred in categories 4 and 5, so the best improvement were in the dry categories. The least change in best corrected visual acuity occurred in categories 1 and 2. The largest change in the central retinal thickness occurred in categories 4 and 5, again, the dry ones, and then the least change in the central thickness in categories 1, 2, and 3, the persistent fluid categories. In conclusion, the authors found that patients with more than 15 fluid-free visits performed significantly better in terms of their vision gained from baseline, their retinal thickness improvements compared with those patients who had persistent fluid at more visits. And the idea of variability in central retinal thickness, those with persistent fluid had more variable thickness, which correlated with the vision gains. The subgroups of subretinal fluid versus intraretinal fluid analyses tend to indicate that there is less impact of residual subretinal fluid as opposed to residual intraretinal fluid. And again, this was a pooled data analysis across all treatment arms. However, the authors did note a distribution of more patients on brolucizumab in categories 4 and 5, but I would point out that they did not do statistical analysis in this regard.
Thanks so much, Kyle, for that really comprehensive overview of the paper. I know that there was a lot of analysis that was done, so thanks so much for describing that for us so we could chat about it a little bit more easily. Dr. Soares, any sort of quick thoughts on the paper?
Yeah, I think it was a great paper. It kind of assists in our conversation regarding whether or not we can tolerate subretinal fluid in the treatment of wet AMD. It sort of leans towards not tolerating subretinal fluid as much as some of the other studies like the fluid study suggested. I think it is limited. It is a post hoc analysis. I think the categories that they separated into can get a little confusing, but I think in general, it helps suggest that regardless of the fluid compartment, fluid-free visits are imperative. But yeah, I think overall it's a good paper, a good addition to the literature in this sort of debate between can we tolerate SRF or not.
Yeah, definitely. I think that's really interesting. It feels like over the past few years, depending on which study recently came out or which analysis came out, the story is changing on is fluid good? Is it not good? How much do we tolerate and do we not? So I think this definitely adds to it. Kyle, any thoughts about that?
Yeah, I agree that it's a confusing paper with all the categories. As we look at these, the distribution of patients amongst all these categories, when you really look at is really all over the place. And like, the number of patients in category 1 is kind of small, that like there were not a lot of patients in the study with persistent fluid compared to, most people were really dry or just, had mostly fluid-free visits. And that mucks it up even more when you try to do these analyses between these seemingly somewhat maybe a little bit arbitrary cohorts of defined fluid-free visits. But I think it's a nice attempt at a post hoc analysis.
I agree. I think that whenever you see a paper that has so many different categories and so many different ways of analyzing it, it makes you take a closer look at it and try and understand why that was done and what the intention was, and if that's to sort of cover up anything that's there. All right, let's take a quick break, and then we will hear more in depth about this paper on the other side. Welcome back to the new Retina Radio Journal Club with VBS. Let's get into a longer conversation about the paper that Dr. Kovacs summarized in the first part of this episode. Where we left off, we were talking about the different categories that the authors used to do this sub-analysis. One of the things that I was struck by is trying to understand why they chose 5 different categories of fluid-free visits. And at first glance, it sort of makes sense to sort of break it down. The numbers generally look okay. But then as I sort of took a closer look at the amount of patients in each group, you realize that the data is somewhat skewed, and maybe think that those selections of different category was done to sort of best take advantage of those patients. I don't know, Kyle, if you had any sort of thoughts about how that analysis was done.
Yeah, I mean, I think they ended up with a even numbering system, right? That made it by time period to be an even distribution, but the patients are not evenly distributed amongst. And I'm sure that if you look at like where within those groups people fall, I bet you that they are clustered, even more so in certain areas. And there is probably some added benefit to having the groups thresholded exactly where they are. That gets sort of a little bit distribution that gives them a little more statistical power. But that's a very cynical take on the bracketing here. But it still allows for some analysis that may be less accessible probably if it wasn't for the existence of these buckets or thresholds here.
I think one positive outlook on why they bucketed the way they did is if you just look at the naming of each category. I think when a general physician looks at this, you kind of think of, okay, my patients sort of fall into one of 5 categories. There are patients who are never dry. There are patients who are always dry. And then there's patients kind of on that spectrum, almost like a Likert scale. So I think from that perspective, if you don't look at the number of patients per bucket, that sort of makes sense from a colloquial standpoint. But then again, like you mentioned, it sort of distributes it a little funny when you look at actual patient numbers. So perhaps they could still have had the same categories, the same 5 Likert categories, but then just distributed it evenly by patient rather than by number of visits. And that might have been a more statistically thorough way to do it.
Yeah, I think that's a really good point. And then the funny thing is, on top of it, it gets even more complicated because beyond having those 5 different categories, you could analyze it in 3 different ways, right? If they didn't have any intraretinal fluid, if they didn't have any subretinal fluid, or if you couldn't have either. So there's like all these different layers. As I was trying to read the different tables and graphs in the paper, there's some statistician who spent quite a long time analyzing all these groups and hopefully got his due credit, or his or her due credit for all of the work that they put into this paper.
One positive, one strength of the paper that I thought compared to some of the other fluid analysis papers was that, I think they mentioned it in their discussion as well. A lot of the other papers on whether or not subretinal fluid is tolerable are more cross-sectional analyses, which really pair the anatomic and morphologic structure of fluid to visual outcomes. So it's more of like a cross-sectional look at fluid. And this is more of a dose-dependent sort of kind of comprehensive look at fluid over the number of visits that a patient has. And I think as a clinician, that's the way that I think of it more as, how many visits is this patient having that they're having fluid, as opposed to, oh, now they have, this central amount of fluid. And so is that going to immediately affect their visual acuity? I think it's that dose-dependent response as a clinician that I really think about. So that's one other, strength of the way that they designed the paper.
I think that's a good point. I mean, I think that there's been a lot of attention paid over the past couple of years to, how bad is intraretinal fluid? And especially more, how bad is subretinal fluid? Is it good? Is it not good? How much should we tolerate? But then there's also been a lot of papers looking at sort of volatility of fluid and sort of the visual outcomes that are associated with this. And I think their metric is somehow bringing those two together, in a way that sort of makes sense from a clinician perspective, right? You see a patient, they're either dry or they're not dry. And that's the terms we use with our patients and we use when we're thinking about it. So maybe this is a different way of thinking about it that actually brings those two things together.
Yeah, I totally agree with both of you. And Rebecca, that the longitudinal nature of it, I think, is a better reflection of our practice as opposed to the cross-sectional. What do you do with a single data point? Well, no, we're following our patients longitudinally. These are cumulative decisions that we're making, and having some sort of data to help guide our, negotiations with the patient sitting in front of us, I think is really valuable. This is, a clinical trial, we all know doesn't reflect the real world practice. There's lots of studies saying that we undertreat our patients in the real world. And I don't know about you guys, but I always find that it's a negotiation with my AMD patients, kind of always negotiating for fewer and farther between, or they have to take a trip and there's always some. And so having some data that is better at helping us negotiate those conversations or agreements with our patients, knowing that we have some safety of what we're able to tolerate, I think is really powerful. So I definitely applaud them for doing this sort of sub-analysis of the different types of fluid.
Yeah, I think that's a really sort of good point. And I think, whenever I look at analysis like this, I try and think about how does this actually impact, me in the clinic and seeing patients. How should this change my practice? And I was interested to sort of hear your thoughts about how does this, does this analysis change how you sort of approach patients? Like, obviously, Kyle, like you mentioned, it's complicated and there's a lot of factors at bay, but like Rebecca, has this have any impact on sort of how you would approach your AMD patients?
I think it actually makes me second guess a little bit how I've been approaching my AMD patients. It's, I'm a year out of fellowship now, so I've taken a lot with me from fellowship. And a lot of my attendings during fellowship really emphasized that, if you can tolerate a little bit of subretinal fluid and it allows you to extend the patient, then perhaps that's a good benefit for the patient and improves their compliance and adherence to a long drawn out treatment schedule like we have, especially because a lot of my mentors were involved with the loss to follow-up studies at Wills. And so really, if you can maintain the patient in your clinical practice, I think ultimately that's the best outcome for the patient. So you kind of have to, like you were saying before, you kind of have to optimize fluid and adherence. At the same time, I think this changes my mind just a little bit because I think, previously I would take a look at subretinal fluid and it would just be a sliver and I'd be like, don't worry about it at all. But now I'm sort of thinking, okay, well, I think the message is mixed here. I think, you have to weigh the data, but perhaps if there's a way to negotiate with the patient so we can get a little less of that subretinal fluid at each visit, maybe that's a better attitude as opposed to just not caring about subretinal fluid at all.
Yeah, I think you hit like, it strikes both ways, right? Like that we want things to be drier and yet give some data about, well, if they're not dry, there's something that's a little bit more palatable or tolerable. And even though this is a long term of follow-up, it's still not as long as we follow with some of our patients, where we are talking about years and years and years of continued therapy and what's the burden of doing, extensive treatment. So there are different phases of a relationship with a patient where this can guide us in different parts of that, right? Where maybe earlier on in the disease, we are really striving for more dryness, or somebody who's later on who, not uncommonly is more in these category 3 or 4 patients from this study that has a little bit of recurrent SRF, and I keep talking about trips because I have one patient that's on my mind. He keeps asking, but I got a trip. It's post-COVID and my wife and I haven't traveled in 6 years. And we were supposed to go to Italy and we're so healthy and this is our time to go. It's like, well, you should go on your trip, like that there's some complex negotiations that this helps us navigate at all parts of patient care.
Yeah, I think that's a really good point. I mean, I think it also speaks to the need in our field, although we have great tools in our toolbox for things that are excellent at drying, but have excellent durability too. And sort of potentially, maybe on the horizon, there's treatments that don't require, injections at the same frequency that we give them. But thank you so much for both of all of your contributions and discussion points. I think this was great. I want to thank the audience as well for listening to the new Retina Radio Journal Club with VBS, and please stay tuned for further episodes. Thank you, everyone.